Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
Again, thank you everyone for joining us today for this program on interventional pulmonology and its role in lung cancer with Dr. Lakshminarayanan. This is Emily Brown, the Program Director at Cancer Support Community Atlanta. We do these programs, educational programs every month, and we are very grateful for our presenters today, giving their time to do this for everyone. Just a reminder that you are going to be muted throughout the program, but we welcome you to ask any questions that you have in the chat box at the bottom of your screen, and we will answer those questions as they come in. So I think we will go ahead and get started with first our introduction of our moderator today. So our moderator today is Melissa Morrison. She is a clinical coordinator at the lung cancer program system-wide at Northside Hospital Cancer Institute. She received a Bachelor's of Science in Nursing at the University of Miami, a Master's of Science in Nursing at the Kennesaw State University, and a Doctorate of Nursing Practice at the University of South Alabama. She is a board-certified nurse practitioner, member of the Pulmonary Hypertension Association, and she has special clinical interest in lung cancer, pulmonary hypertension, COPD, and asthma. Outside of work, Melissa enjoys running, golf, travel, and quality time with her family. So thank you, Melissa, so much for being here today.
Thanks, Emily. Our speaker today is Dr. Venkatesh Lakshminarayanan. He goes by Dr. L. He is a medical director of our Interventional Pulmonology program at Northside Hospital Cancer Institute. He attended Rush Medical College in Chicago, where he received his medical degree and PhD in immunology and molecular biology. He is triple board certified in pulmonary, critical care, and internal medicine. I have personally had the pleasure to work alongside with him as a nurse practitioner for many years, so it is my honor to introduce him to you. This is Dr. Lakshminarayanan.
Thank you, Melissa and Emily. I really appreciate it, and to everyone who's come out today. So what I wanted to do, go over some basics of what interventional pulmonology is, how it fits into lung cancer, both diagnosis as well as treatment, and then go over a couple of cases or examples of what that looks like and why it's important in all this. So kind of the big objectives we'll go over. I want to go over just briefly some lung cancer statistics. I'm going to start really at the basics of it, which is what's a bronchoscopy and what's it for, and how it's related to lung cancer staging, and then interventional pulmonary medicine, and what our role is as an interventional pulmonologist, and then go over some of those treatment, diagnostic and treatment options that we have. So my disclosure statement, I don't have any affiliations or interests with anyone. So just to give you guys a little background, and I assume that if you're on this talk, you probably know most of this already, but these statistics are a little old, but they still are pretty dramatic to prove the point. Lung cancer still by far the leading cause of cancer-related deaths in America, smoking obviously being the primary driving cause. But if you take non-smokers, or what we call never smokers, out, it still fits in the top 10 of cancer-related deaths. And the current problem is with lung cancer is that it takes more lives than any other cancer. And again, one of the although this is from 2012, this still holds true now. And it's quite a staggering fact, but about 160,000 Americans will die each year from lung cancer. And that's more than the combination of breast, colon, and prostate. So this brings us now to some of the U.S. cancer comparisons and where kind of lung cancer screening came from. So obviously with breast, colon, and prostate cancer screening, we've had screening guidelines for a number of years. And while these screening guidelines have shown that you screen early and at appropriate intervals, and you have better survival outcomes. Obviously, breast is 88%, and colon and prostate, as you can see, based off of those screening guidelines that we come up with. But at this point, we still had with all those survival rates, we had no survival rates, or sorry, we had no screening tests for lung cancer. And essentially what's called the number needed to treat, or the number of cases you need to do to save one life. So a breast mammogram screening saves one patient for every 1,550 that you save. So a fairly big number, and really is what you're looking at is smaller and smaller. When you get down to the fact that if you get a CT, a low dose lung cancer screening CT, one person will be saved out of 320 people. So what I wanted to bring up with all this is that as you look at where these guidelines were, you can see that once they were in place for prostate, colorectal, breast, between when they were started, or before there were screening guidelines and then when there were screening guidelines, you see, just as an example, prostate cancer went from 68% survival up to almost 100% survival. And the big one that we talk about a lot is breast, going from 75% up to almost 90%. But lung cancer, without its screening guidelines, we were still at an abysmal kind of 15 to 16%. And that's hadn't changed from 1975. So then in 2011, there was a large trial. It was published in the New England Journal. We had the National Lung Cancer Screening Trial, and it looked at using low-dose CTs and if this would reduce mortality, death rates, improve length of life. They looked at over 50,000 patients in 33 different sites. And the big conclusion was low-dose CT reduces mortality. And from this, the United States Preventative Task Force developed guidelines. These guidelines were originally in 2013 and then have just been updated this past year. So for those patients who fall kind of into the same criteria, just like breast and prostate or colon cancers, we have certain guidelines. And right now we look at any individual who's between the ages of 80 and 50 with a 20-pack year history of smoking. So a pack a day for over 20 years, currently smoking or quit in the last 15 years. This is what we look at for screening people. And then we screen people annually based off of this, no different than you would for breast or colon, just at yearly intervals or shorter intervals, depending on what's found on the scan. It's covered by private insurances and Medicare. So where does this all fit now into lung cancer? So with these nodules that people find or any abnormalities we may find on screening, we have kind of a multidisciplinary cancer clinic, and everyone's involved. Pulmonary medicine, so lung doctors like myself, thoracic surgeons, medical oncologists, radiation oncologists, our pathologists who help us look at those tissues, and the radiologists who help with these scans. And so within pulmonary medicine, and there's interventional pulmonology, which is a subset of it. I tell people it's a lot like cardiology. You may have a cardiologist who takes care of your heart, all your heart issues, but if you have a heart attack and you need a catheterization, there's an interventional cardiologist who does those procedures in the same idea. So really part of interventional pulmonology is to try to shift this paradigm that we've always looked at. Again, for years and years, we've been finding later stage cancers. And it was really the biggest question, or the big umbrella to this, is how do we find cancers earlier? How do we find smaller cancers? And then how do we stage them? So the old idea here was that traditionally, if you had a nodule that was in an airway, and I'll show you what that all means, you would reach it with a bronchoscope. And if you didn't, and it was in the lung tissue kind of that surrounds the airways, then you typically would have a radiologist put a biopsy in through the skin. Now, the benefits of those radiology biopsies are the diagnostic rates were much higher, but you needed larger nodules initially. Patients had to present with symptoms, which typically went along with larger lesions and most likely later stages. And that's kind of borne out in all the literature. About 80% of those people were stage 3 and 4 cancers. And what does all that mean? That what that translates to everybody is late stage diseases, stage 3B and above, means shorter life expectancies. So now the new idea with interventional pulmonary medicine was now to look at not just those nodules that are in the airway, but those that are in the tissue, and to be able to diagnose and also stage cancers at the same time. The problem was initially that we were only seeing about 40%, able to get to 40% of those nodules as well. We could get to smaller ones. We could look at, a lot of these benign or benign nodules or patients who didn't have symptoms. And the goal ultimately was to get to these earlier stages. So as I've kind of touched on before, this is kind of the best way I can explain what interventional pulmonary medicine is, that it is that subspecialty of pulmonary medicine. We're using minimally invasive bronchoscopic techniques. So a bronchoscope is no different than an endoscope. So if you ever get an EGD or a colonoscopy, it's the same idea. I tell people all the time, and Melissa's heard me say this for years. I tell people when they're getting it, I said, it's the same concept, except I'm using a scope that's about the size of a pen head, and I'm going into your lung as opposed to the EGD. And we use these, or we also have techniques now where we can do what the radiologist does, where you go through the skin into these lesions. And so the idea now is that you have two different ways to get at one lesion. So as opposed to having a patient have to go through a procedure and maybe for whatever reason, there's not a positive result, or you're worried that you didn't get in the lesion, or the lesion continues to grow after it's biopsied. Well, we can, rather than worrying the patient, having to come back, get another scan, get another biopsy, we can do this all in one time. And I'll show you what some of that looks like. And then again, one of the benefits here is that interventional procedures are typically less invasive, give us faster times to diagnosis, and reduce the risk of complications. A lot of this also goes with staging and with our surgeons. We work very closely with our cardiothoracic surgeons. The historic way of biopsying, let's say, lymph nodes or a nodule many, many years ago was to biopsy it surgically, or to biopsy the lymph nodes surgically, and which was a fairly big surgery at that time, required recovery, and then moving on to a lung surgery. So with interventional pulmonary medicine, we're able to biopsy these with just a scope. And so kind of the basics of bronchs, and I've touched on this a little bit, and I'll show you some pictures of this. But what is a bronchoscopy? It's really just a procedure that allows you to look at directly into the airways, the bronchoscope or the bronchial trees. And then it allows you through that scope to place instruments that you may need to either biopsy or get samples from, or it also has suction in there. So if there's bleeding, you can irrigate it and suction it out. And so we have two types of big bronchoscopes that we use: rigids and flexibles. Flexibles are probably 99% of what we use. It's a flexible scope, as the name says, and it allows you to get into small, tight airways and kind of go through all those twists and turns. And again, this can be used a regular bronchoscope can be used to biopsy some of those lesions I told you that's outside of an airway and in the lung tissue rather than in the airway itself. It can be used, historically, we used to use it with X-ray or what we call fluoroscopy, where if you were getting to a peripheral lesion and it's really, you get to small airways and we couldn't tell, and you would just go based off of images and anatomy. Well, adding the X-ray in there helps reduce that kind of guesswork in those really small airways. I tell people it's like the old game, is it behind door number 1 or door number 2, that we would often have to see in these small airways. It was very hard to see. And so by using some of these other things, initially fluoroscopy and now electromagnetic guidance and ultrasounds, we're able to increase the accuracy at which we're able to diagnose these lesions. And then the newest and biggest part of interventional pulmonary medicine, I think, which is the bulk of what most interventional pulmonologists and general pulmonologists now who do this procedure see, which is really about biopsying the lymph nodes that are in the middle of the chest. And I'll talk about why that's important in a second. So this is that basic bronchoscopy that I've been talking about this whole time. So you can see it's really just a scope. As I said, it's about the size of a pen head, and it has a light source, so we're able to work. It has a fiber optic cable in there, so it has a camera, and then there's a little light source on the sides and a little channel here where we can put different tools through, whether it's things to biopsy, things to put a needle into, or to flush fluid through. And here are just some of the things that we put through there. So we have these little forceps that you can see. Let me do one, excuse me. These little can you guys see that laser pointer there? Just turn that on. But you can see these forceps. They can be used to grab or biopsy nodules. Sometimes if a mass is in an airway and it's a tight turn, or it's a very bloody area and you don't want to take a big biopsy out of it, you can use these little brushes and kind of scrape it and get some cells from it and kind of show us find out what these cells are. Now, as I was talking about these bronchoscopic trees and the airways and how these bronchoscopes are important to get into these smaller, tighter turns, I say this in the clinic, and I say this to my patients all the time. Imagine the lung is essentially almost two organs. There's the spongy part, that's the lung tissue that does all the oxygenation. And then there's the tree part that's embedded in all of it, and literally looks like a tree that's upside down. So your windpipe, your trachea, is at the base. And then as you go out to the smaller airways, they get smaller and smaller. And as we go out further and further, now with all these new techniques, we're able to get into these tiny, tiny airways. And I know these pictures are small inside, but this just kind of gives you an idea of what we're looking at directly when we're looking through a scope. Now, again, with those peripheral nodules, someone comes in and they say they have a lung nodule. This has been kind of the algorithm or the pathways that we all look at. So someone comes in with a peripheral nodule, and if it's in an airway, a bronchoscope is a better way to go. And if it's in the lung tissue, interventional radiology or radiologist putting a needle in was historically the better way to go. The problems were, as you can see here, without a visible airway, it's used when there's not a visible airway, and they can do it under CT guidance. The problem is the pneumothorax rates can be on average 30%. They range from anywhere from 5 up to 60%, depending on where you have it done and by whom. The more consistent places are doing them, these rates are lower. The less emphysema that's in an area, the less risk, then these rates are lower. But when you do these IR procedures, they have great yields, absolutely. But now you've gone through one procedure, gotten this biopsy. Now you have to go to staging. Now you have to go back for a second procedure. This is always done with a bronchoscope to stage pathologically. And so this is a big key to everything that we do, because now the patient, this is all patient-centered, because the patient has got a nodule, it's been biopsied. Now they have to wait for those results. They follow up with their doctor. Then they have to go back for another procedure now to have these lymph nodes staged before we can talk about treatment. Now, some of us, that might not seem a lot of time, but when you have cancer, I think that's, time is always of the essence. Now, if you, in those cases where you get a benign nodule, you follow them out. And if you, in those rare, again, here, they have very high yields, but in those 10 to 20% of cases where they're not diagnostic, well, now you have to go back for a second biopsy, or do you watch this, or do you go to a surgical biopsy? And that's been kind of the traditional way. With bronchoscopes, the yield was much lower initially, and our yields were higher if we had an airway going directly to it. If we didn't, our rates of success were down around 40%, but also our complication rates were much lower at about 2.5%. And again, treatment, and part of the bronchoscopic treatment algorithm here is that I went straight to treatment because you could biopsy this and do the lymph nodes at the same time. So that would shorten timeframes and give you some degree of staging. But if it's benign, you would follow it. But again, here, if you get something that's kind of non-diagnostic, now do you decide, well, do I go to an interventional, a radiology procedure where the yield is going to be higher, but my rate of collapsed lung is going to be higher, or do I watch this? So that kind of creates the diagnostic dilemma for a lot of us. And how's it staged? So patients, we talk about, whenever we say staging, I like to tell people there's really two staging ways of looking at it. There's radiographic, so staging with imaging, and then there's pathologic. And I tell people all the time, I'm nothing more than a carpenter. I measure twice and I cut once. So measuring twice means the CT scan where I find a nodule, an MRI or a PET scan will guide us to where these nodules are or the lymph nodes. And then you need this thing called an EBUS, which is an endobronchial ultrasound, which I'll talk about in a second. And that's really for getting that pathologic staging. So getting invasive staging and sampling those lymph nodes. And then, or we can also do biopsying from outside again. Now, the historic way was a surgical biopsy where they did what's called a mediastinoscopy. This is how they used to biopsy lymph nodes, or a video-assisted transthoracic biopsy where they went through the side of your lung and had to take a piece. Now you would have to do that, recover, and then go back for a surgery. So it used to, historically, that was a long time process. So again, why is lymph node staging important to us? The presence of lymph nodes, especially in non-small cell lung cancers, makes the difference in mortality, so life expectancy for people. So the presence of lymph nodes in the chest can change the stage for cancer and can be the difference between cancers that can be surgically resected, those earlier cancers 3A, or something that's inoperable, 3B or above. And that's where surgery is not an option. And we talk chemotherapy and radiation. And that's not to say that we don't use chemotherapy and radiation in earlier stages. It's just an add-on. It just means that in these non-small cells, if they're earlier stages, surgery, which improves outcomes, is an option. And this is also in the idea also that, a patient is stable enough to undergo a surgery. So what is that EBUS, or that endobrochial ultrasound? It's used for staging of those non-small cell cancers. And it can be used for peripheral lesions, but more for the mediastinal lymph nodes. So the same way that we have lymph nodes in our neck that you can feel when you're sick and you say, oh, my lymph nodes are swollen. We have them throughout our body. And we have them along that airway tree that I showed you. We have lymph nodes all through there. And we're able to access those with a scope where we go through the windpipe or we go through any of those small airways into the tissue around it and access these lymph nodes. Now, what I tell people why this is important and why when we say things are 3A disease or 3B or other, the best example I can give is if someone has a nodule or a cancer on their right side. Well, when we biopsy these lymph nodes, we start on the left side and we look at them and we'll biopsy them. And if there's no cancer, we move closer to that site to see what are the closest lymph nodes that are involved. Now, if you have lymph nodes that are involved on the left side and you have a mass or a cancer on the right side, that's already told me that it's a 3B cancer and we've already pathologically staged it. So this gives us that guidance then. So we're able to do in a couple of hours what used to take weeks to do. Now, that EBUS, as I keep alluding to, it's just an ultrasound on the end of a scope, and it allows us to look at those lymph nodes, be able to see them and biopsy them. And we put these together with the PET scans and the CAT scans, and people always ask, well, why do I need this procedure if I have a PET scan? Well, a PET scan helps give the picture, but it doesn't tell you what's in that tissue. And that's what you really need, is you need tissue to know what this is. Now you can sample these lymph nodes, and we often go back and use these to get more tissue later if we know someone has metastatic disease for some of the trials that we use as well, where they need more tissue. We can always go back with a scope like this, which is minimally invasive, can be done fairly quickly, 20, 30 minutes, and to get more tissue. So this is just to give you kind of an idea. Many of you have seen CAT scans, but if you look here, just to really point out the big thing, hopefully you can see that pointer, that big thing right there next to it. This is an airway and this is a big lymph node right here. And if I look at it with an ultrasound, I can see a lymph node here. And this lighting up part is really a blood vessel. So we're able to separate it out, and the scope can tell us what's blood vessel, what is not. So I'm not putting a needle into blood vessels there. And you can locate these lymph nodes, and we'll just slowly move through the airway and biopsy each of these. And so this is what lymph nodes look like with an ultrasound. This is what you're looking at. It's no different than the ultrasound that you may use at your cardiologist to get an echocardiogram or to look at a baby. And so as I was talking about, just to put a picture with that description, we have all these lymph nodes in our chest. And we'll take scopes and we'll use those PET scans to kind of give us an idea, or the CAT scans, what's large, what's not. But we'll go down and systematically look at all these lymph nodes. And if they look enlarged, or we saw them light up on the PET scan, we'll biopsy them. And we all start on the opposite side from a cancer and move towards it. And that's what's going to stage the cancer. And what that really all boils down to is, what's that prognosis going to be? And that's why this is so important.
Dr. L, I have a question. So if a patient has a PET scan, and you were saying, depending on if it was active and the size and location, when would one of these procedures be important to have and move forward with?
So excellent question. So really in two ways. In this day and age, there is a rare time that someone doesn't need to have an EBUS to have tissue of that mediastinum, of those lymph nodes. Everyone who has a potential lesion, if there's anything on the PET scan that looks enlarged, or with a PET scan, there's also a CT portion. So if they look enlarged or they light up, that's concerning. Now, what I will say is PET scans are excellent tools, but they're just that, they're just tools. And they have, just like all these other things that I have been talking about, they have sensitivities. How much do they pick up? And so they're about 70 to 80% sensitive. Now, if anyone's had a PET scan, you know that they'll tell you before they do it, they'll say the night before, don't drink any coffee, don't exercise. If you have any type of infection, upper respiratory or otherwise, postpone the scan. And the reason is because it's just about uptake. So that's that. The stuff that lights up is anywhere that there's more activity. Can it be cancer? Absolutely. But can it be an infection? Absolutely. And can it be anything else? If someone has any other rheumatologic diseases or any other, potentially systemic diseases, things can light up. And so it's really hard to kind of use that alone. Now, I'll say probably the one time, again, if we look at a PET scan and someone has things that light up in the chest, but they have something that lights up in the hip, just as an example, again, using that idea of you go to the furthest spot away, because if you biopsy that hip and it's there, then you know that's the furthest spot. And so you've already staged it based off of just one biopsy. So that's where that whole cancer conference comes in at the beginning that we talked about. When someone comes in and they have a potential mass and a concern for a cancer, we all sit down and talk about it. We look at these scans. If someone's had a PET scan for some reason, we can say, yeah, that'd be the best place to go. But if you have a biopsy, 99% of the time, there'll be an EBUS involved. And again, that kind of goes to I think I'm, kind of said this over and over, which is if there's a biopsy there, we can biopsy a peripheral lesion as well as biopsy the lymph nodes all at one time. So really speeding up the process of diagnosis and time to treatment. So again, the old dilemma that we talked about was those airways or lesions that were outside the airway now versus the ones that are inside. And so I just put this back up here just to kind of refresh everyone's memory of that. And then say, so now those staging factors, which we've kind of talked about. And so one big thing that I thought of a few years ago, and it really kind of hits home, I think, for all of us who are practicing medicine, but also to try to get this to explain it or to kind of visualize it for the patient. I tell everyone, think of things as spheres, not circles. Everything's got 3 dimensions to it. So really, when something enlarges and we say, oh, it's, X number of millimeters, but it's gone from 2 millimeters to 3 millimeters, and someone says, oh, that's not a lot. Well, it really comes in context. So if you look at it, it's really about the volume of something. How big is that thing getting? So the difference between a 1 centimeter nodule that we see in 2 dimensions versus a 2 centimeter nodule really means, as we can look at it in 3 dimensions with some of these procedures, it's really 8 times larger, not just twice as large. And kind of dramatically, a 1 centimeter lesion versus a 3 centimeter lesion, it's 27 times larger. So there's more, it's larger, but what that translates to is really more involvement of the tissue around it. And that can be blood vessels, lymph nodes, any of the other structures there. So that's why it's so important to have these staging things arranged before we go to surgery. And this is why, I don't want to speak for my surgery colleagues, but really this is why the goal of clean margins is that because it is 3-dimensional, we're not just cutting it in 2 dimensions. That's why these things are so important. So this is just to give a little overview of some of the newer techniques that we're using that go along, where I've talked about kind of using 2 techniques in one. So you can biopsy, someone comes in and they have a peripheral nodule somewhere in the lung tissue and they have lymph nodes. Well, we have these new systems where we can take a CAT scan and it uses electromagnetic connections and some software. And what we do is we get a CAT scan the day of the procedure, and someone will have these electromagnetic pads on them, and we can transfer the data into some software. And I literally, before the case, I will create a 3-dimensional image of their lungs. And then from that, we can create a map or a pathway. So where we've traditionally followed with just a bronchoscope and said, I know where I'm going anatomically, now we've increased that confidence level or that chance to get to those lesions. And I'll be able to look directly through the scope, but I'll also have kind of a video image at the same time. I tell people it's like the GPS in your car. And so this is now at the same time, we can also do an outside biopsy, which these yields are very similar to those done in radiology, but we can do it all at one time. So now we're talking about going from, let's say, biopsying a peripheral lesion, come back, go over the data, biopsy the lymph nodes, and that could be a week to 10 days in between for the patient. Now we're talking about doing this in an hour or 2. So now we can find out someone has cancer and stage it all at one time. And this has really been one of the key goals that we've tried to really focus on through the IP program here. So this is just a picture of what I was describing. So you're able to look, you'll have a lifetime image, but you'll also have this generated image of someone's airway. And at the same time, that CT that I just used, I can look at those CT images at the same time and then create this 3-dimensional tree. And so I think the best thing to look at is, I have a little video here. Let's see if this plays. I guess this was working earlier. So you can see, if you look in this upper corner, you can see where it's taking you up to that lesion that way. You can see it that way. In the center lesion, you can see what's called a fly over or fly through, where you see on the screen what I'm seeing through the scope as well. And then and then I can look at the CT images and adjust the scope. So all these tools are going through the scopes. So this is a scope that has all these devices that we can put through there and can kind of localize these lesions. Now, the next iteration or the next step in this technology has been getting to those really tiny, tight airways with something that doesn't require to hold a scope that long, because you think there's always the technical part of trying to get into that area and hold it and be able to biopsy and then go back and get the same area over and over again. And that's where the new robotic bronchoscopies have come in. And this is the next phase in diagnosis and hopefully treatments with lung cancers. So the Monarch system is one that we use here at Northside. And it's been around for only a few years. And it allows us to get deeper into these small areas and maintain control of the airway at the same time with a scope that's driven by a robot, and you're driving the robot with a handheld controller. And so this is kind of a big picture of what it looks like with a tower setup where you're able to look at the image standing next to the patient. And then this is kind of the body of the robot that's set up. I think I have a video here. This kind of gives you, just running through it, this is just what the robot looks like. I use this CT scan and I can mark all this out even that way. It creates similar images, but now rather than me holding that scope there, I'm using a handheld controller and I'm able to move the robot arms and a scope through there and even tighter turns. And then it can telescope out, you can put needles out into these airways, and you can make these very fine adjustments. So it kind of takes away some of that element of human error of us trying to hold in place while we're trying to reach these. And now I can do this and make these tiny changes. As you see here, this individual's doing it. They're making, millimeter changes, and we have kind of these targets. And you can see if you want to biopsy through the center of a lesion, along the sides of it, because you may have different characteristics for a cancer. So it gives us higher yields with this. And then this is just another kind of animated view of what this looks like. So the patient has been intubated, put on a ventilator, and then we put the scope in like that. And then we advance the scope through that, and we can drive it all the way out. And you see here, you have multiple screens you're looking at, and you can see as you get into small airways, small airways, normally scopes would stop there, but now we can telescope through there and get into the smallest airways and go essentially all the way to the outermost part of the lung, right at the level, almost to the level of the skin. So now we've actually taken out that other procedure where we're going from the side. Now we're doing it through the airway. And the important part here is that it reduces that rate of pneumothorax, and it increases the yield that we can get from these smaller lesions. And you have one of these screens, the one that was in your upper left corner that you can see is actually a lifetime image. So it looks just like a regular scope. And then you're able to biopsy this, and you can biopsy multiple lesions this way. So it really adds another, and you can combine this with the endobrochial ultrasound, that EBUS, and you could biopsy a lesion and then biopsy all the lymph nodes. And one of the benefits of all of these, as I was saying, our pathologists are involved. They look at these live time. So as I'm biopsying, they'll tell me, oh, this sample has nothing but blood or has just benign tissue. Oh, this sample has something that looks abnormal. And when they say that it's abnormal, then I can give them bigger pieces to look at. And so we have live time data there with the pathologist looking at it and able to tell us that, yeah, I think I see a cancer here. You are in a cancer, get more of that tissue, or, oh, this area doesn't. And so really that staging thing will give us answers the same day to some degree. And they're typically finalized within a few days. So this, again, we've now cut things down from weeks to days.
Dr. L, I have a question. Is there a difference between a lesion and a node?
Yeah, so good question. So lesions, so we often refer to, I'll expand that a little bit and say, to answer that. So we'll talk about lesions, masses, and then and then nodes. So when we refer to nodes, that's lymph nodes. So that's where the lymph node is enlarged. And we're going based off of what we see on the CT scan. Now, sometimes that is actually when you get into an airway, you see, nope, that's actually tumor that's invaded into those lymph nodes. And it's also in the airway. But node typically refers to lymph nodes. Now, when we refer to something as being a lesion or a mass or a nodule, those are all based off of size. So nodules, if someone says, oh, they have a X millimeter or centimeter nodule, it's typically something that's below 2 centimeters. 1 to 2 centimeters is kind of the max that we go to. And this is why a lot of times people have what we call incidental nodules. And your pulmonologist or your doctor may say, we're just going to repeat a scan. This is what their thought process is. The likelihood of this being a cancer is low. It's better to just repeat imaging. Now, a mass suggests something that's greater than 3 centimeters or involves other tissue structures around it. So if we saw something that is about 3 centimeters or a little less, but it looks like it's attached to the lining of the lung based off of imaging, then it's considered a mass more than it is. And that has, now does that make it worse? Not always, but it's really based off of size. And a lot of us will use some of these terms interchangeably, but I like to be really specific when I say this is a nodule, this is a mass. And then when someone says infiltrates, that just means there's an area, but it's not very well circumscribed. It's kind of diffuse looking. So moving forward, this is just another video, and you can see in the inlay in that left corner, that really gives you a good picture of what they were going after. And as you can get all the way down here, it may not project real well, but one of the great things about these new systems is it gives you visualization all the way out. And in this case, they were able to get all the way out to this airway. All the electromagnetic and robotic pictures looked like, hey, there's something actually in the airway. And now they're able to look, and with the regular scope, you wouldn't be able to see something's in the airway. And this person was able to make this little turn and then go and see that once they pull back a little bit here, it's actually, there is something actually blocking one of these teeny tiny airways so that you can get large core samples that way. So that's, again, you never lose visualization with this. And that's the key to all of these. So once, there it is right there in that little about 3 o'clock position, you could see kind of briefly. But what it gives you is now you can hold this scope there and it can stay there for as long as it needs to. And you can use different tools that you may need to biopsy it to, to get enough tissue for you or to try to remove some things that are in the airway.
And Dr. L, is there ever a time where you would not use a Monarch for someone you suspected had lung cancer, like there was another test that they may need?
Yeah, absolutely. So it really comes down to the interventionalists, what they feel is the best test or the best way of accessing something. For some people, yeah, the robot is perfect, especially for smaller, more peripheral lesions. It's better for things that are more central. I mean, one of the things you need for both the Monarch as well as the Veran navigation system that I showed you with the scope is that you need a new CT scan. Now, they're low dose CT scans, but some people don't want to have another scan. And I completely agree with it. But if it's something that looks like a large central lesion and doesn't need that level of complexity, or it doesn't require that level of to be that sensitive to get there, that you can use a regular scope, then we try to take the one that's least invasive. Sometimes we biopsy things and it's not done under general anesthesia. It's just done with conscious sedation. As you saw in that little video mock-up, it had somebody that was on a ventilator, which is how a lot of our cases are done, but some that are central. If someone has a central lesion, there's no reason to put them through extra anesthesia or a longer case. And by longer case, I mean 30 minutes to an hour versus 5. So if you want to pick the best diagnostic and least invasive test with the least number of potential complications anytime you pick these things.
You just answered my next question on how long these procedures typically take.
So depending on how many you combine together and how long, if you're biopsying one lymph node versus 3 or 4, versus a navigation or a combination of them. I tell people in general, expect the case itself to be about an hour. The setup is probably more. And that means when they're getting that CAT scan right before those things and getting people into the right positions, those can take another 30, 40 minutes. But for those people who are just coming in and getting an EBIS, on average, it's about 30 minutes to biopsy all these lymph nodes. But for some cases, it's a little bit longer, but on average. And so I've done a lot of talking about diagnostic parts of IP. And so just kind of briefly, I'd like to talk about some of the, just to touch on a couple of the kind of therapeutic options that we have for tumors. So as I was talking about all these, surgical resection is always the first thing that we look at for primary lung cancers, but also metastatic lung cancers. But some of those patients cannot tolerate a surgical procedure. So they may have resecting a large part of their lung might reduce too much of their lung function afterwards. So that wouldn't, although you're taking out the cancer, you can make their lung function worse. They may have a lot of comorbidities, which makes it harder for them to undergo a long surgery. And then about 10% of people who have successful resections, we will follow these over time with repeat imaging. They may develop a second new cancer, maybe on the same side, maybe on the other side, or maybe next to that lesion over time. Now, a second operation may be possible, but again, there's a lot of criteria that go into that. Maybe that it's not an option. Now we use something called photodynamic therapy. That's an alternative that we can use that'll spare the lung function and allow you to treat locally. And one of the great things about it is it can be used in conjunction with someone who's getting chemotherapy, who's getting immune therapy, and then even radiation is, in terms of timing, if it's timed within a week or 2 weeks after or before, it can be done with radiation too. So it's just one more tool that we can use in the treatment arm. So what is photofrin? So it's used to treat micro-invasive disease. So disease, non-small cells I put here, but we also use it for metastatic diseases. And I've used it in everything from renal cell cancers to melanomas to anything where there's a potential obstruction of an airway. It helps, as I said, reducing that obstruction, and it can be used with traditional chemotherapy, but also immune therapy, radiation as well. Now, what is photofrin, or what is photodynamic therapy? So we use a medication called photofrin, which is essentially an inert iron-based molecule. And so iron gets taken up by all your cells, primarily those that have a lot of blood supplies to them. So obviously things like cancers will have a lot of blood supplies, so they get taken up more. The medication's not active unless it's activated by a laser light. I tell people that I use the world's largest pen light. And so what we do is we infuse the medication a few days before, allow it to circulate in someone's body. And the infusion only takes 15 minutes or so. They go home. They come back in a few days later, and we do this first bronchoscopy. And some are done under general anesthesia, depending on the tumor size. Some are not for this first one. And I can put a scope all the way into these big obstructing areas. And I put this little laser through the scope into it, and I turn it on, and I essentially treat the tumor locally. And when that light hits that medication there, it activates the medication locally and starts to kill the tumor there. We come back a couple days later, allow that tissue to die, and we pull out some of that tissue, and then we repeat this sequence over a couple of days. And this can typically be about 3 different procedures over a week's period of time, but I'll show you some of the kind of dramatic results that we see in these cases and where this can be used. So here's just a patient I had. She'd already had squamous cell cancer a number of years ago. A lot of her treatment options had been exhausted. She had bad emphysema, so surgery was obviously not an option. But in her situation, it was worse because it involved her windpipe. And as you can, just to kind of give you an idea, this kind of 5 o'clock to 9 o'clock area that looks very yellow, whitish, that's all tumor. So you can't resect that, and it's a very bloody area. So we had decided to use photodynamic therapy with what I was describing. So we go through there, I've treated, and then we start to resect it. And we can use, when I say resect, we can use a lot of different tools. We have some freezing tools, which is essentially liquid nitrogen. I have some cutting tools, cutting lasers that tell people it's like an acetylene torch that's very low energy, and I'm able to cut these areas. And as you can see, slowly but surely, we kind of open this area, we cut all this off. And here in the picture on your left, you'll see at the 9 o'clock to 11 o'clock, there's definitely some residual disease. And then here as well, there's some disease in the right side of picture at about 9 o'clock that shows some residual disease. And we go through there and we take this all out. And then after 5 to 7 days, we go back, we look, and this is what the airway looks like. So we've taken out all that local disease. And the most important thing is that we've improved her symptoms. So we've opened an airway and allows all that other lung tissue to work because it's not obstructed. And this is just another picture to show you. This is someone, it can be used, again, as I said, on multiple types of cancers. Here's a breast cancer where there was a lesion blocking this airway completely. And with using this photodynamic therapy, we were able to open it and debride it and pull all this out. And so the last thing I want to talk about is one other thing that we do, which is mechanical stenting of airways, much like the cardiac stents that you think of. This is just opening a tube. So in our case, we're opening an airway. In the case of the cardiologist, they're opening a blood vessel. And so what it does is it temporarily opens an airway before, after you're doing something like PDT or debriding something mechanically to open the airway. Through a scope, you can put in one of these self-expanding stents and kind of guide yourself out to these areas. And these are typically done in large areas or large airways. So things like the windpipe or the big divisions to the right and the left, that we can often put that in. And there's a number of different types of stents. There's wire ones, and then most people use one that are silicone coated. Now these are temporary stents, meaning that they typically stay in for, on average, 4 to 6 weeks, because we don't want to leave them in too long because they can grow, tissue will grow around it into the wall or block the stent and then you can't remove the stent. So we don't really like them to go longer. We often use it as a temporizing measure to keep an area open where we might be going back in and debriding it over and over to kind of reduce that area that's all inflamed that may close an airway down. So here's a different case. So this is an individual who had tumor, and this was going down that right side of the lung. So you see all of this is tumor, and you can see just a small airway in the center. And one of the reasons that we do these things is that all the tissue below this looks normal. So they're just not able to use that lung tissue. So we try to open it up. So kind of here, what we do is we put in one of these expandable stents. It's guided down. I'm able to open it and it's able to push all that tissue back. And then doing certain things, I can debride some of this before, then put the stent in. And then there's some other techniques we can use to debride these tumors through the stent as well. We leave it, we let it stabilize for a few weeks, and then we go back in and we can pull these out. And then kind of in conclusion, for my part, I'd just like to say, we work with our referring physicians, our teams. We have a great, group of people that we work with. It makes my job very easy. We now have a nurse navigator who also helps kind of guide people through this. So at the bottom there, you can see there's a referral number, and patients can self-refer as well. So the nurse navigator will really help you kind of see what are the next steps that I need to do. When do I see the doctor? What scans will he or she want? And then what's the next step? And then guide you through the procedures and follow up. And did the case go okay? And are your follow-up set up, and is all the pathology back? So really kind of helping you navigate each of those steps until they can kind of hand this off to the surgeons or to the oncologists. And then down there, that website, that's just our Pulmonary Critical Care of Atlanta. That's our practice. If you want to see any other information about this or some other detailed things.
Wow, Dr. L, that was great lecture. I really appreciate, all this information that you've been able to provide for us. Just being in the world of pulmonology for many years, we've definitely seen the advancements with technology, which have really provided accuracy and definitely decreased complications for our patients. So I think it's very important that we have these options, here at Northside. A couple of questions for you is, if a patient has contrast allergies, what other kind of imaging can they get done to evaluate a nodule?
So good question. So typically for me, I tell my patients that because I have the advantage of using tools like EBUS where I can look at these lymph nodes, contrast really helps just look at structures, vessel structures, or lymph node structures to kind of define them. So I rarely use contrast unless I am worried about an area that it might be small or it might be right next to a blood vessel. But all these other scans that I showed you are all done without contrast. And they're all low dose radiation, much like and that's the other big question. People say, hey, I just had a scan. Do I have to get another scan? Well, it's incorporated all into the procedure and it's all covered under people's insurance or commercial insurances, but also under Medicare and Medicaid, that it's all part of the same procedure, that it's necessary. And for those people who say, well, I just really don't want to scan. Yes, we can use old reference scans, but creating those trees and all those things, it's like putting tracing paper over something. So you're going to have some shift. So it makes it a little technically a little more difficult. It's not impossible, but we always try to work with our patients on that. And kind of going off of what Melissa said, it just reminded me of a big thing that I didn't get a chance to really highlight in the program as a whole for our cancer program. Something I'm extremely proud of is that, on average, from the time a patient sees a pulmonologist or sees their doctor with a new nodule to the time they get diagnosed, go through all these things, staging, and get to treatments, national averages are about 30 up to 50 days. Now, cancers don't typically grow that fast, but still there's that worry that you've got a cancer that's growing and there's not a treatment plan. And so really we focused on trying to cut that down. And we're at a point now where from the time you see a pulmonologist with us to the time that you're ready to start treatment, whether that's surgery, chemotherapy, or radiation or other modalities, is about 12 days, 10 to 12 days right now. So, and my goal is with our team is to really shorten that even further, to get you into treatment and some of these, these endoscopic treatments or bronchoscopic treatments earlier than that.
That's great. That's great. And just lastly, what kind of doctor can order these particular tests for a patient? Is it anyone, or they need to be referred to a specialist?
No, anyone can order. I mean, in terms of the procedure part, specialists in any field, I think the best way to explain it is tell everyone they're kind of the gatekeeper of the procedure. You do as much as you can up to that point. So we have some people who send us patients who they just had an incidental nodule and they say, you figure it out from there, which is completely fine. Other people, they say, these are their risk factors. So I went and got this scan and this scan. Can you see them now? Because I think they need a biopsy, or do you think they need a biopsy? And I get referrals from other pulmonologists who do all the workup, treat the cancers, or work in a place where they can, but they don't do any of these procedures. So they'll send their patients to me to treat, to do these procedures for them, and then we get them back to them.
Wonderful. And I think we've answered everyone's questions at this point.
Great. Thank you guys all. I appreciate your time. And my information's all on that website, and Melissa and Emily should have it as well if you want to get it from them. If you have any other questions.
Yes, thank you
Dr.
both
Al.
so much. Yes. thank you, Melissa, as well for fielding all those questions. We had a lot of questions coming in. We've also had people ask about if this is being recorded. Yes, we are recording this presentation and it will be available on our website, cscatlanta.org, in the coming weeks. So you can look out for that. Thank you both. Again, do you have any closing statements?
First, I want to thank Dr. L so much for providing all this information to our patients who are listening. And, you know, working at Northside Hospital, it's amazing just how far we've come and the advancements we've made to really help out our patients. So thank you.
Dr. L, any closing thoughts?
No, I think I've probably said all that I can say about all this, but like I said, I'm happy to help in any way that I can. If other questions come up, don't hesitate. Our phone number is on there. Call us.
Thank you so much. We're getting some feedback in the chat right now that this is the best presentation on lung cancer they've ever seen. So thank you so much for taking time out of your day. I know you've got to get back to your patients, so I won't take any more of your time. But everyone, thank you for joining us today. And join us next week. We will be doing a presentation on advancements in treatment of pancreatic cancer with Dr. Abdallah, and that'll be next Thursday at noon, and you can register on our website. But again, thank you all, and we will hopefully see you again soon.
Thank you.
Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.